Welcome back to the deep dive. Our mission here is to take stacks of complex research, distill them down, and give you the essential knowledge you need to be deeply informed quickly.
Today we're tackling something that really hits home for a lot of people.
It really does. We're taking on the challenge of chronic pelvic pain, specifically the kind that comes with endometriosis.
And if you or, someone you care about is dealing with this, you know that the pain is it's not straightforward.
Not at all. It's often heterogeneous, it's unpredictable, and so often it just doesn't respond to the treatments that we think should work.
Things like surgery or hormonal treatments. You do the thing that's supposed to fix the problem, and the pain is, well, it's still there.
That experience, that persistence and confusion around the pain is exactly what we're here to unpack today.
For way too long, chronic pelvic pain was just treated as this one single thing. But the data, the science, it just doesn't back that up anymore.
So this deep dive is really built around that idea of moving beyond a simple diagnosis.
Exactly. We need to get into detailed pain phenotyping. We've synthesized a major scoping review, a study of studies, really, that focuses on characterizing 3 distinct types of pain.
And one of them is the big one we're focusing on today.
Right. The newest, and I think often the hardest to treat, it's called nociplastic pain. And it stems from a mechanism called central sensitization.
Understanding that distinction is not just some academic exercise, it's really the key to getting people the right treatment.
And it absolutely is. I mean, if you treat the wrong kind of pain, the outcome is almost always failure. And that's a cycle we really, really need to break.
So let's set the stage. What are we basing this on?
Okay, so the source material for this is a huge academic effort. It's a scoping review that started with almost 400 citations.
Wow.
Yeah, and they whittled that down to 30 really high-quality papers, all focused on one thing.
Which was?
How do we assess nociplastic pain and that underlying mechanism, central sensitization, in people with endometriosis?
And what did they find right out of the gate?
Well, the initial finding tells you everything you need to know about where we are right now. There's just a striking lack of standardization.
Meaning everyone is kind of doing their own thing.
Exactly. The sheer diversity of methods being used to try and measure this type of pain, it's a major roadblock to progress.
Let's break that down because I think that diversity really paints the picture of why it's so hard to compare studies right now.
It's a complete patchwork.
Yeah.
So of the 30 papers they looked at, 14 of them relied only on patient-reported questionnaires.
So just surveys, subjective data.
Just surveys. How do you feel? What are your symptoms? Then you had 6 papers that used semi-objective measures, like something called quantitative sensory testing, or QST.
A physical battery of tests.
Right. And only just two studies relied only on standard clinical assessments. The rest, about 8 of them, used a mixed approach, trying to combine questionnaires with some kind of objective measure.
That really does sound like the research community is just grasping for an answer. They're looking for a tool that works in a clinic but is also sensitive enough to actually identify this problem.
That's the perfect way to put it. The lack of consensus on how to even measure it is the first huge hurdle.
And that need for precision brings us right to our first section. We need to define exactly what nociplastic pain is and why it's in a category all by itself.
Right. We have to unpack what makes it so different from the kinds of pain we've been talking about for decades.
Historically, our vocabulary for pain was, well, it's pretty basic.
Very basic. Pain meant something was damaged. That was it.
But as neuroscience evolved, that simple model just couldn't explain chronic conditions anymore. So in 2021, the International Association for the Study of Pain, the IASP, they formalized an update.
And that update brought in the precision we desperately needed. So now we really operate with 3 distinct pain phenotypes.
Let's start with the one everyone knows.
Okay, so the first and most familiar is nociceptive pain. This is the classic expected pain. It happens because of actual or even just threatened damage to non-neural tissue.
So not nerve tissue.
Right. It activates these special receptors called nociceptors. It's the body's standard immediate alarm system, a fire alarm going off because there's a fire.
And in endometriosis, this is the pain from the lesions themselves, right? The inflammation, the irritation of organs.
Exactly. It's the direct result of the physical problem. So in theory, if you remove the lesion or suppress the hormones feeding it, that pain should go away.
Okay, so that's number one. What's the second category?
The second is neuropathic pain, and this is a whole different beast. This pain is caused specifically by a lesion or a disease of the nervous system itself.
So the nerves themselves are the problem.
The nerves are the problem. In endo, this often happens when you have these deep infiltrating lesions that physically damage or compress peripheral nerves.
And that feels different, doesn't it?
Very different. Patients often describe it as burning, shooting, or radiating pain, sometimes numbness or weakness. It's nerve damage, plain and simple.
Which brings us to the newest and I think the most confusing category for a lot of people, nociplastic pain. The definition hinges on this idea of no clear evidence of damage. Why is that detail so critical?
Because it completely changes what we're supposed to be treating. Nociplastic pain is the term we use for pain that comes from altered nociception, meaning the pain signaling system itself is dysfunctional.
Even though there's no ongoing tissue damage to explain it.
Right. There's no obvious lesion, no clear disease of the sensory system that can account for how bad the pain is or how widespread it is.
I've heard the analogy of the nervous system's volume knob being stuck on high.
That's a great way to think about it. If nociceptive pain is the fire alarm going off because there's a fire,
Then nociplastic pain is.
nociplastic pain is the alarm system being so sensitive that it goes off when someone lights a match in the next room, or maybe just because the wind blew too hard.
So the fire, the original tissue damage might be gone, or it might be tiny.
Exactly. But the sensitivity of the entire alarm system, the brain and spinal cord, has been fundamentally changed. It's amplifying signals that should be harmless, or sometimes it's just generating pain signals all on its own.
So how on earth does a clinician actually diagnose this when the definition is about the absence of something?
It's tricky.
Hmm.
The IASP gave us a set of clinical criteria, basically a checklist, based on the patient's history and symptoms. So to be categorized as having possible nociplastic pain, you have to meet 4 criteria.
Okay, walk us through those 4.
First, the pain has to be chronic, so lasting at least 3 months. Second, the pain distribution has to be regional, not just one discrete spot. Think widespread pelvic tenderness, not a pinpoint of pain.
And third,
Third, and this is key, the pain can't be fully explained by those other 2 mechanisms, nociceptive or neuropathic, after you've done a full workup.
meaning the surgeon has gone in, they've removed all the visible endo, the nerve tests are normal, but the person is still in significant pain.
Precisely. And the fourth criterion is that they have to show clinical signs of pain hypersensitivity. Their pain response is just way out of proportion to whatever stimulus is applied.
And that's just to get to possible.
That's the threshold for possible, yeah. It gets more specific if the symptoms are more systemic.
That's when you move into a higher probability category.
Exactly. That's when we call it probable nociplastic pain. For that, you have to meet all 4 of those criteria, plus have a history of hypersensitivity in that whole region of pain, and you have to have 1 or more very specific comorbidities.
Let's talk about those comorbidities, things like sensitivity to light or fatigue. Why are those such strong clues that the problem is centralized?
Because they point away from the pelvis and directly to the brain. The list includes things like increased sensitivity to sound, to light, to odors. It also includes chronic sleep problems, crippling fatigue, or cognitive issues, what a lot of people call brain fog.
These aren't pelvic symptoms.
Not at all. They're signs that the central processing unit, the brain and spinal cord, is stuck in a state of hyperarousal. It's affecting sensory and regulatory systems all over the body. When you see a patient with severe pelvic pain who also can't handle bright lights and is exhausted all the time, you have to suspect a centralized problem.
I see. So we have possible and probable, but the source material really stressed a major limitation here.
This is the critical piece of uncertainty. There is currently no clinical criteria for definite nociplastic pain.
So it's a description, not a hard diagnosis.
Exactly. The term was only formalized in 2021. And this lack of a definitive objective marker is why you see so many of these other conditions like fibromyalgia or irritable bowel syndrome or bladder pain syndrome all getting looped into this category.
They're all considered chronic overlapping pain conditions.
Right. They all seem to share this core mechanism of heightened pain perception, but we don't have a blood test for it. We have to rely on these symptom checklists.
So let's talk about that mechanism. Because nociplastic pain is the description of the state. The engine driving it is central sensitization, or CS.
Correct. Central sensitization is defined as the amplification of neural hypersensitivity. And to really get it, it helps to contrast it with peripheral sensitization.
Okay, so peripheral sensitization, that happens out at the site of the injury.
Right, it's local. It's what happens from the inflammation or damage from an endo lesion, for example. It results in what we call primary hyperalgesia, increased sensitivity right at that specific spot.
If a lesion flares up, The tissue right around it gets really tender. That's PS.
You got it. Central sensitization is what happens when the spinal cord and brain take that signal and just run with it. They amplify it and spread it.
And the clinical sign of that is different.
Very different. The hallmark of CS is secondary hyperalgesia. This means you have increased sensitivity outside the original area of injury. So the pain might have started deep in the pelvis, but now their abdomen is tender to the touch, or their lower back is killing them.
And this is also where allodynia comes in.
Yes, allodynia, which is pain from a stimulus that shouldn't be painful at all.
Look, clothes touching your skin.
The classic example. The light pressure of clothing or even water from the shower suddenly becomes painful. It means those incoming nerve pathways in the spinal cord have become so sensitized that they're just firing off pain signals for everything.
And there's a really tight link with mental health here, too. This isn't just a physical wiring problem.
You cannot separate them. There are powerful, well-established links between CS and things like anxiety, panic attacks, and depression, which is so important because it tells you that any effective treatment has to target the CNS, not just the tissue in the pelvis.
It's that classic chicken and egg question, right? Does the anxiety drive the sensitization, or does the chronic disabling pain drive the anxiety?
It's almost impossible to untangle, and clinically, it doesn't really matter. You have to treat both at the same time.
So let's bring this all back to endometriosis patients. Why is getting this phenotyping right so critical for their long-term health?
Because it's the best explanation we have for why outcomes are so varied. Study after study shows that endo patients who have more of these nociplastic features, more signs of central sensitization report, much, much worse pain.
Across the board.
Across the board.
Yeah.
More severe overall pelvic pain, more deep dyspareunia, which is painful sex, more dyschezia, painful bowel movements, and more chronic back pain.
And this detail really turns our old understanding of endometriosis on its head.
It really does. Because this correlation, this link between CS and severe pain, it exists independent of what the surgeon finds. It doesn't matter what type of lesion they have or where it is, or even if they've had surgery before.
So you could have a patient with just a few tiny spots of endo, but a highly sensitized nervous system.
And she could be in far more pain than someone with stage 4 deep infiltrating disease whose nervous system is calm.
Which means you can perform a technically perfect surgery, remove all the pathology. But if that CNS is still revved up and hypervigilant, the pain is not going to go away.
Exactly. The central processing problem needs its own treatment. Being able to assess for these features is everything because it allows us to create a personalized plan that goes beyond just looking at the pelvis. If we keep throwing surgery and hormones at a patient whose brain is the main problem, we're ignoring the real driver of their suffering.
Okay, so since we don't have a single definitive blood test or scan for this yet, clinicians and researchers have had to lean really heavily on patient-reported questionnaires.
They've had to, yeah. These tools basically try to use subjective reports, feelings of tenderness, stress, fatigue, to guess at what's happening objectively in the central nervous system. They're looking for proxy data.
The source material looked at 3 big ones. Let's start with the one that came up the most often, the Central Sensitization Inventory, or CSI.
The CSI is it's very widely used and also widely debated. It's a 25-item questionnaire. You get a score from 0 to 100, and it's designed to measure the presence of these CS symptoms.
But it's not just a pain scale, right? It asks about a lot more than that.
Much more. It really focuses on the psychophysiological symptoms of daily life that go along with centralized pain.
Like what specifically? What is a patient actually filling out?
Well, it asks about things that strongly suggest the nervous system is dysregulated beyond just the pelvis. So specific questions about sensitivity to light, to sound, to smells, to temperature. It also asks about things like restlessness, headaches, dizziness, and those cognitive issues we mentioned.
And it has been specifically validated for this group of patients, which is important.
That's crucial, yes. There's a clinically significant cutoff score that's been established for endometriosis in chronic pelvic pain populations, the score of 40 or higher out of 100.
40. So if a patient hits that 40 mark, what does that tell a clinician about what might happen next for them?
The clinical significance is huge. Patients who score 40 or above on the CSI consistently have poorer outcomes. They report higher pain intensity, more disability, and, very importantly, higher rates of failure with first-line hormonal treatments.
So it's like an early warning sign that the standard approach probably isn't going to work for this person.
It's a massive red flag. It also tells us something about the breadth of their pain experience.
How so?
Higher CSI scores are strongly associated with having multiple chronic overlapping pain conditions, so not just endo, but also IBS, or tension headaches, or fibromyalgia. It suggests that one underlying process of centralization is causing problems in multiple body systems at once.
And these scores can even predict what happens after surgery.
Yes, they act as independent predictors of poorer quality of life, even after a successful surgical intervention.
But this is where the big debate comes in, the one the literature is full of. If the CSI asks about stress and brain fog, how do we know we're measuring a neurological issue, central sensitization, and not just the incredible emotional stress that comes from having a chronic, debilitating illness?
That is the million-dollar question hanging over the CSI. There's a lot of evidence that the CSI is, at least in part, measuring a state of psychological hypervigilance. It's picking up on stress, anxiety, depression, and especially something called pain catastrophizing.
Which is the tendency to really focus on, magnate, and feel helpless about pain.
Exactly. So the argument is, are we measuring neurological rewiring, or are we just measuring the emotional fallout of being sick for years? It muddies the water.
And yet there is some evidence that it's not purely subjective, that it does connect to something physically measurable.
And that's the defense of the CSI. Studies have found a moderate negative correlation with an objective lab measure, the pressure pain threshold, or PPT. The correlation was about 3-hour NICE in 2,255.
Okay, let's translate that for everyone. What does a correlation of negative 0.25 actually mean?
It's an inverse relationship. It means that as a patient's self-reported CSI score goes up, so they're reporting more symptoms, their ability to tolerate physical pressure measured by the PPT goes down.
So they become more physically sensitive to pressure.
Right. Now, negative 0.25 isn't a perfect correlation, but it's significant. It shows that this questionnaire is capturing a real sensory change that we can objectively measure in the deep tissues. It's evidence that it's a legitimate proxy, even if a person's psychological state is also a big part of their score.
Which makes it a really powerful screening tool, even with those limitations. Okay, let's move to the second proxy tool, the Fibromyalgia Survey Score, or FSS. Why would researchers use a tool for fibromyalgia to study endometriosis?
It comes directly from that idea of chronic overlapping pain conditions. The theory is that endo and fibromyalgia share central sensitization as their core underlying mechanism.
So since fibromyalgia is sort of the classic nociplastic condition.
Exactly. So the FSS, which is a validated tool for diagnosing FMS, is used as a direct proxy to measure how much CS is present in the endometriosis patient.
And how is the FSS scored? Is it similar to the CSI?
It's a bit different. It has two main parts, and the total score goes up to 31. The first part is a 19-point body map to see how widespread the pain is. The second part is a 12-point scale that assesses the severity of symptoms like fatigue, unrefreshing sleep, and cognitive problems. If you score 13 or higher out of 31, you meet the criteria for a fibromyalgia diagnosis.
And the predictive power of this tool is where it gets really interesting, especially when you're talking about making decisions about major surgery.
This is a game-changing piece of data. One study looked at whether the FSS could predict if pain would persist after a hysterectomy, a huge operation that's often done to try and cure pelvic pain.
And what did they find?
The finding was staggering. For every single 1-point increase in a patient's preoperative FSS score, there was a 27% increase in the odds that they would still have persistent chronic pelvic pain after the surgery.
Wait, a 27% higher risk for every single point on a pre-op questionnaire? That's incredible.
It completely reframes how we should be doing preoperative counseling. It means this simple screening tool could be a powerful predictor of surgical failure, no matter how good the surgeon is.
Because if the patient's system is already centrally sensitized, the surgery itself, an invasive procedure, isn't going to fix the core problem.
It might even make it worse. It provides powerful evidence that we have to start screening for these features before we recommend surgery. It should be standard practice.
Okay, our third patient-reported tool is the Pain Detect questionnaire. This one's a little different. It was originally designed to find neuropathic pain.
That's right. Pain Detect is a short 7-item questionnaire. It asks about symptoms like burning, tingling, or pain from light touch to see if there's a neuropathic component to a person's pain. The score lets researchers group endometriosis patients into different profiles.
And what are those groupings?
Generally, there are 3. A nociceptive profile for scores of 12 or less, a mixed profile for scores between 13 and 18, and a neuropathic-like profile for scores of 19 or higher.
And the surprising finding was how many women with endo fell into that last group.
It was a huge number. One big study found that 40% of women with chronic pelvic pain were classified as having this neuropathic-like pain, even though their primary diagnosis was endometriosis.
40% is a massive chunk of the population to have symptoms that don't fit the standard inflammation model. What else did that group report?
They reported significantly higher levels of psychological distress, more anxiety, more depression, and also just higher overall pain intensity scores compared to the nociceptive group.
So again, we see that tight overlap between these neurological type symptoms and psychological comorbidities.
Exactly. And since we know pain detect scores correlate strongly with the FSS, and we think of FMS as a nociplastic condition, it really suggests that pain detect is picking up on nociplastic features, not just purely neuropathic ones.
And to confirm that, they did something really smart. They tried to link the subjective answers on the questionnaire to objective sensory tests.
This is where these tools gain real credibility. They took a sample of women with both endometriosis and painful bladder syndrome, and they looked for direct correlations between specific pain detect questions and specific QST tests.
And they found them.
They found clear links. For example, the heat pain threshold, so the objective measure of when heat becomes painful, that correlated with the patient's answer to the question about whether cold or heat was painful for them.
What about for touch?
For mechanical sensitivity, the pressure pain threshold, the PPT, showed a strong correlation, about $3.4777, with the question that asks, is slight pressure triggers pain?
That is a strong correlation for this kind of research. It's compelling evidence that when a patient says light pressure hurts, it's because they objectively have a lower tolerance for deep pressure.
It really reinforces the idea that these questionnaires aren't just measuring general distress. They're genuinely identifying changes in sensory processing that are linked to these nociplastic features.
So far we've been focused on what the patient reports. But for research, the gold standard for measuring these sensory changes is still quantitative sensory testing, or QST.
Right. This is the search for objective proof. QST is this big, complicated battery of standardized tests. It's designed to detect both sensory loss, so numbness, and sensory gain, so hyperalgesia and allodynia.
And there's a standard protocol for this, right?
The gold standard protocol that researchers aim for is from the German Research Network on Neuropathic Pain, the DFNS protocol. It includes 13 different test modalities.
13. That sounds incredibly time-consuming and expensive. What kind of tests are we talking about?
It is resource-intensive. It requires specialized, calibrated equipment. The tests fall into two main groups: thermal and mechanical. So thermal tests use these little devices that can rapidly heat or cool the skin. They measure things like your threshold for detecting heat and cold, and then the threshold where that sensation turns into actual pain.
And mechanical tests.
The mechanical tests measure thresholds for different kinds of physical touch. So the threshold for just detecting a light touch, the point where a pinprick becomes painful, and the pressure pain threshold, the PPT. It also measures something called the wind-up ratio, which is a really crucial indicator of centralization.
Let's zero in on the PPT, the pressure pain threshold. The review flagged that one as being the most prominent semi-objective test used across all the studies. Why is it so important?
The PPT is crucial because it uses a quantifiable, measured force, usually from a device called an algometer, to detect central sensitization in deep tissues like muscle, not just on the skin.
So a lower PPT score means it takes less pressure to cause pain.
Exactly. And a reduced PPT is considered a very strong, measurable sign of that widespread, deep tissue hypersensitivity that's a classic feature of nociplastic pain.
So if QST is the objective gold standard, why is it so hard for researchers to compare results from different studies? Why isn't everyone just using it?
The problem, and the review really highlights this, is the lack of standardization in how it's actually done. Even when different studies say they're using QST, they're often deviating from the strict DFNS protocol in significant ways.
Can you give us an example of that? How does that variability show up?
Oh, it's everywhere. For PPT, some studies use a small electronic pressure algometer that applies force to a tiny calibrated point. Others will use an inflatable pressure cuff, like a blood pressure cuff, that squeezes a whole limb.
Those are measuring completely different things.
Completely different things.
Yeah.
One is localized pressure, the other is deep, widespread pain tolerance. But both get reported in the paper as just QST, but you can't compare the results.
It's like they're speaking different dialects of the same language. That must be incredibly frustrating for people trying to synthesize all this data.
It's a massive hurdle. The wind-up ratio is another great example. It measures how the nervous system amplifies repeated stimuli. But the DFNS protocol specifies a very particular stimulus, and many studies just use their own methods with different frequencies or techniques. The data ends up being non-comparable.
Okay, so let's move out of the high-tech lab setting.
Yeah.
What can a clinician actually do in their exam room to look for signs of this sensitization?
In the clinic, the focus is often on looking for signs of something called viscerosomatic convergence.
That's a mouthful. What is that?
It's the key theory. The idea is that chronic, high-volume pain signals coming from the visceral organs, so the endolesions, start to sensitize the nerve cells in the spinal cord.
And once those spinal cord neurons get sensitized, they start broadcasting pain signals to other parts of the body that share the same spinal nerve level.
Exactly. That sensitization in the spinal cord leads to widespread hyperalgesia and even physical changes like thickening and hardening in the skeletal muscles of the abdomen, the lower back, and the pelvis.
And clinically, that shows up as myofascial trigger points.
Right. Those are those highly irritable, tender knots in the muscle that a clinician can physically feel. They use them as a proxy for this abdominopelvic tenderness and allodynia.
Are they a definitive sign of central sensitization in someone with endo?
And that's the big caveat. While these trigger points are super common in patients with these overlapping pain conditions, the sources are careful to say there's limited evidence that every endo patient with trigger points definitely has CS. They're a sign of chronic signaling and pelvic floor dysfunction for sure, but maybe not the smoking gun for CS itself.
So to get something more reliable than just poking for trigger points, specialists developed a more structured tool, the convergence, pelvic, and perineal, or PP criteria.
Yes, and this is a great tool because it tries to standardize the clinical exam. It's a structured 10-item checklist. It forces the clinician to systematically check for pain and sensitivity across 4 different areas of the body: the urinary and digestive tract, the genital area, the skin, and the muscular system.
So it's much more comprehensive. And how well did it work when they tested it?
It performed really well. It showed excellent specificity and sensitivity, 87% and 95% when they compared its results to a diagnosis made by an expert pain specialist. A score of 5 out of 10 on that checklist is used to reliably identify the presence of this widespread sensitivity.
And that's something a doctor can actually do in a regular appointment, unlike a full QST workup.
Exactly. It's feasible.
Okay, so we've established nociplastic pain is real, it's common in endometriosis, and we have some tunes to detect it, even if they're not perfect yet. Now we have to get to the most important part, the clinical implications. Why does this matter for the patient? And it comes down to this idea of bottom-up versus top-down pain.
This distinction is everything. It dictates the entire treatment strategy. If a patient's pain is mostly nociceptive or neuropathic, the problem is bottom-up. It's peripheral.
Meaning the signals from the lesions or damaged nerves are driving the problem.
Correct. So the treatment should be peripheral. Hormonal suppression, surgical excision. You remove the stimulus.
But if the pain is primarily nociplastic, it's top-down.
It's top-down. The amplification in the nervous system is now running the show, largely independent of what's happening in the pelvis. The fire might be out, but the alarm is still screaming.
And if you use those standard bottom-up treatments on a top-down patient,
You hit a wall of treatment failure. And the stats on this are just stark. The sources highlight that within 5 years of standard endo treatment, surgery, hormones, whatever, over 40% of patients have persistent or recurrent pain.
40%. That's a massive failure rate.
It's a huge failure rate. And it's probably the single strongest argument that we are profoundly underdiagnosing and undertreating the centralized nociplastic component in a huge number of people.
So if we identify a patient with a high CSI score or a high FSS score, they need a completely different playbook. They need an interdisciplinary approach.
The evidence for this is just overwhelming. We have to use a model that targets the local issues, the central nervous system, and the psychosocial factors all at the same time.
And there's good data on this.
There's a landmark randomized controlled trial that our sources referenced. It compared standard treatment to a comprehensive, multidisciplinary pain program. The results were incredible.
What were they?
After 1 year, 75% of the patients in the multidisciplinary program reported clinically significant improvements in their pain and their ability to function. In the standard treatment group, it was only 41%.
That is a massive difference. So let's dive into the details. What does that successful interdisciplinary model actually look like?
The absolute foundation of treating centralized pain is pain neuroscience education, or PNE. This is all about teaching the patient what is actually happening in their body.
So it's about validating their experience, but also correcting their understanding of pain.
Exactly. It focuses on 2 things. First, explaining neuroplasticity, teaching them that pain is an output of the brain, it's a perception of threat, not always a direct measure of tissue damage. This helps reduce that pain catastrophizing we talked about.
And the second part?
The second part is validating their pain, especially if they've had tests come back normal, and showing them how things like stress, emotion, and their social life can literally turn the volume of their pain up or down.
And just that education alone can make a difference.
A huge difference. Studies show P&E by itself leads to less pain, less disability, and better physical function. Just understanding what's happening makes it less scary, which calms the nervous system down.
Okay, beyond education, what about lifestyle?
Health behavior changes are another core piece,
Mm.
especially because of that high overlap with things like IBS or painful bladder syndrome. So dietary strategies can be huge,
Like a low FODMAP diet for IBS symptoms.
for example. But also, more generally, just encouraging a diet rich in whole anti-inflammatory foods can help reduce chronic pain severity and improve that whole gut-brain connection.
And then there's the psychological piece, which needs specialized professional help to manage those top-down drivers of pain.
Absolutely. Psychological treatments are vital. The sources highlight a few, starting with cognitive behavioral therapy, or CBT. CBT helps the patient identify and challenge those automatic negative thoughts they have about their pain.
So instead of this pain means I'm broken forever, it's this pain is a signal from a sensitive nervous system.
Exactly. Then there's acceptance and commitment therapy, or ACT. It's a bit different. ACT focuses more on accepting difficult thoughts and feelings and committing to actions that align with your values, even when the pain is there.
And both of those have been shown to help.
They lead to better mood, better function, less anxiety, and less catastrophizing. And CBT specifically is also great for treating the secondary problems that come with chronic pain, like insomnia and sexual dysfunction.
Finally, we get to the physical treatments, but with this new understanding.
Right. This is where site-specific manual physiotherapy comes in. And this isn't just general stretching. This is highly targeted, hands-on treatment from a physical therapist who specializes in the pelvic floor.
And this has been proven to help with things like painful sex and painful periods.
Significantly, it addresses the consequences of that viscerosomatic convergence. It helps release the tension, the spasms, the trigger points that develop because of the central amplification. It's breaking those local feedback loops and teaching the nervous system that that area is safe again.
So the full model is really P&E and psychology to quiet the central alarm system.
And then manual physiotherapy and lifestyle changes to normalize what's happening in the body itself. It's a comprehensive approach that recognizes pain as biological, psychological, and social. And often it includes other things too, like trigger point injections or specific nervous system modulating medications.
This deep dive has made it incredibly clear that the pain from endometriosis is it's profoundly complex. It goes so far beyond the lesions themselves.
It's a systemic issue of nervous system dysregulation. And understanding and identifying this nociplastic component is the only way we're going to move the needle on treatment success.
So, to synthesize the main finding here, we have a whole bunch of tools we're using to screen for this. The CSI, the FSS, Pain Detect, a QST. But they're all fragmented.
We're missing a core, validated, and clinically feasible set of methods that everyone can agree on and use. The research is all over the place, which makes it really hard to standardize treatment.
And we have to remember, the category itself is brand new. The term nociplastic pain was only formally adopted by the IASP in 2021. The science is still racing to catch up to the clinical reality.
That newness is exactly why we need more high-quality research, specifically in endometriosis populations. We need to move from using these general pain questionnaires to tools that are precisely tailored for this specific group of patients.
And this leaves us with a final, and I think pretty provocative thought for you to consider. Given everything we've talked about, the strong link between high central sensitization scores and poor surgical outcomes, that 40% recurrence rate, we have to ask a really big clinical question. Should standardized screening for nociplastic pain become a mandatory first step before surgical intervention is even offered to all endometriosis patients?
It's a question that challenges the entire surgical paradigm. If our pre-screening flags a patient as highly sensitized, maybe the first-line treatment shouldn't be a scalpel. Maybe it should be 3 months of intensive interdisciplinary therapy and pain neuroscience education to calm that nervous system down first.
We could potentially avoid a huge number of failed surgeries.
We could dramatically reduce that 40% recurrence rate just by making sure our understanding of the patient's pain type is what drives the clinical decision-making from day one.
A really powerful thought on the future of chronic pain care. Thank you for joining us for the deep dive. We hope this has given you a crucial shortcut to being well informed on this vital shift in our understanding.